How do drug concentrations change with aging? Well, drug concentrations are as a result of absorption, distribution, and then metabolism and elimination. So let's look at each. Now, there are changes in absorption, and they consist of these. And essentially, they just result in a delay in absorption of medications. Are they important? Not really, because in the elderly, the vast majority of medications are given on an ongoing chronic basis. So if the drug peaks at 1.5 or 2 hours rather than at 1 hour, it doesn't really matter that much. What about distribution? Well, you get changes in body composition, such as decreased body water and relative increase in body fat. So you get a different volume of distribution. Is that important? Well, not really, because it only affects loading doses. And loading doses are only really given in places like the emergency department or in hospitals. So again, with the vast majority of long-term dosing, it doesn't really matter. What about renal elimination? Well, you do get age-related declines in renal blood flow, renal tubular clearance, and creatinine clearance. And the good thing is that regardless of the mechanism of renal clearance, calculated creatinine clearance is a reliable method of estimating renal clearance. So if the calculated creatinine clearance goes down to, say, half, then the patient's renal clearance of the drug also goes down to about a half. And importantly, it's best to use a Cockcroft-Gault calculation and don't rely on just the creatinine or the eGFR. What about hepatic metabolism changes? Well, there are age-related reductions in hepatic clearance as well. And unfortunately, there's no simple method of calculating hepatic clearance capacity like there is for renal clearance. Is this important? Very much so. So for most hepatically cleared drugs, the concentrations are roughly double compared to younger patients. And more importantly, they're also quite variable. So in some patients, there'll be a little bit more, and in other patients, there'll be 3 or 4 times more. So what's the mechanism of reduced hepatic clearance? Well, there's issues regarding reduced liver size, reduced liver blood flow, but importantly, you get sinusoidal fibrosis. So this limits the amount of oxygen and drug that get to the hepatocytes to result in their clearance. So what does this all mean? Well, lower clearance means higher steady state drug concentrations for the same dose. Lower clearance also means longer half-lives. It takes longer to get to steady state. And in fact, the maximum steady state concentration may occur, for example, after the patient's left hospital. You also get slower offset of effect when the drug is reduced or ceased, so you get longer periods between dosage adjustments. And that's why in the elderly we say, start low and go slow.